Good evening, everyone, and welcome to this webinar hosted by Nutricia. My name is Danny Bear, and in my non-COVID job, I am the Principal Critical Care Dietitian at Guy's and St Thomas's Hospital in London, but I've been working as the lead dietitian at the Nightingale Hospital London for the last 4 weeks. So some or many of you may have tuned into the last webinar that Nutricia hosted on the 6th of April with myself and Liesl Wundrug, where we covered nutrition management of COVID patients in ICU and also presented the critical care specialist guidance for nutritional management of critically ill patients with COVID-19. We really hope that you found that webinar useful and that you've all been keeping well and looking after yourselves and each other along with your patients since then. We felt that now was the right time to give you an update on the CCSG's additional guidance focusing on post-ICU recovery of patients with COVID-19 and also some other additional nutrition management aspects that we thought were relevant. I'd really like to thank Nutricia for hosting this webinar again for us tonight. The additional CCSG guidance on post-ICU nutrition has actually been published today, which we're really pleased about, and it's in the same link that you will have used previously for our guidance on ICU management. So I'm really pleased to say that we've got 3 excellent speakers lined up for you tonight. Our first speaker will be Pete Turner. He's the nutrition support dietitian from Ulster Hospital in Northern Ireland, and many of you may recognise Pete as the BAPEN Programmes Committee Chair. Pete's going to take you through the recent recommendations published by BAPEN and PENG on nutrition support during NIV and CPAP, something I'm sure many of us have had to deal with over the past month or so. After Pete, we'll go on to hearing from Judith Merriweather. Judith is the clinical and academic dietitian at the Royal Infirmary of Edinburgh, and she's going to take you through the evidence around nutritional rehabilitation post-intensive care with specific reference to the new CCSG guidance and also referencing work from her PhD. And lastly, we'll hear from Judith Albrecht. She's the lead nutrition support and critical care dietitian at Yeovil District Hospital. And she's going to talk about the importance of continuing dietetic follow-up for ICU patients on discharge home from hospital. Again, Louise is going to highlight some of the latest guidance from the CCSG. And she'll also, I'm sure, have many pearls of wisdom as she recently completed her MSc Exploring Nutrition Symptoms post-ICU. So I'm sure that will be helpful for everyone. After that, we will take questions. We've got 15 minutes put aside for questions. So similar to the last webinar, if you were involved, down the bottom of your screen, you'll be able to submit questions throughout the webinar. So I encourage you to do that and we'll answer as many as we can. So without further ado, I'd like to introduce Pete for our first presentation of the evening. Thank you, Pete.
Thank you very much, Danny, and thanks very much to Nutricia for inviting me to speak in this webinar. First of all, I'd like to take you back to the happy days before COVID-19 and last year's Belfast BAPEN conference, which was held in November, in which we had a session called Nutrition Mythbusters. And in this session, eminent speakers from the world of clinical nutrition, including Professor Mike Stroud, among others, set out to dispel common myths from the world of clinical nutrition. One of them we looked at, interestingly enough, was enteral nutrition is contraindicated in non-invasive ventilation. And tackling this myth was Peter Collins, a specialist respiratory dietitian from Queensland, Australia. And he certainly succeeded in dispelling the myth because the multidisciplinary audience, you can see at the top there, resoundingly voted and had busted the myth. Now, this audience was multidisciplinary. There were dietitians, specialist nurses, specialist physicians and surgeons from both the UK and the Republic of Ireland, and there was virtually the whole of BAPEN Council there. And what we kind of agreed in the NIV session was that there are problems with enteral nutrition in non-invasive ventilation, but they can be overcome and the risk can be minimised. And this has actually turned out to be really good in the current setting because it acted as a springboard for BAPEN and the BDA specialist groups to come up with some guidelines and recommendations for enteral feeding in non-invasive ventilation and CPAP. First of all, then, I think I should just cover exactly what is non-invasive ventilation and CPAP. Now, some experts get very pedantic about these definitions, and others are fairly easygoing about it. But I shouldn't worry too much about the definition, but the nutrition challenges we face in them are kind of common, so don't worry too much about them. But the types of things you might see are non-invasive ventilation, and this is where air and oxygen are delivered through a tight-fitting mask at a varying pressure, the inspiration pressure being greater than the expiration pressure. The commonest brand name you'll hear is BiPAP or biphasic positive airways pressure. Another form of basic respiratory support is high-flow nasal oxygen, where high-flow humidified oxygen is actually given through nasal cannulae. And another very common form of basic nutrition, not nutrition support, respiratory support that you will have heard of is CPAP. You've probably even heard about this on the television news. And this stands for continuous positive airways pressure, where there's a positive air pressure put into a tight-fitting mask or a hood, and this keeps the alveoli open in the lungs and increases the surface area for gas exchange and oxygen exchange. As I said, these are all forms of basic respiratory support. Okay, so just to look at some pictures of these various things. So I mentioned there was a tight-fitting mask that's often used, so this might be used in non-invasive ventilation, such as BiPAP, or in CPAP. High-flow nasal oxygen, here's a picture here, and you can see there's the high-flow nasal spec. This is probably the best form from a nutrition point of view because it doesn't restrict eating as much as some of the other types. Also, quite a good form is the CPAP hood, and on the left there's a picture of actually one of the COVID victims from Italy. I think this was used quite a lot in Italy. And this is where there's a hood or a helmet that actually has that continuous positive airway pressure that keeps the air space open in the lungs, the alveoli open. I use this a lot, or I encountered it a lot when I worked in the ICU in Liverpool, and I found this was actually quite good. Some of the hoods, like the one on the right, have actually got a little window you can open up. You can offer sick feeds and things like that through. Now, malnutrition is a big problem in NIV and CPAP, and patients on NIV often fail to meet the requirements orally. One study showed that in the post-ICU phase, patients might be consuming less than 650 calories a day. And we know in the general patient population, the general hospital population, that poor nutrition is associated with increased morbidity and increased length of stay. Actually, in COPD patients on NIV, so chronic obstructive pulmonary disease patients on NIV, if they're malnourished, there's a study showing that they will have increased mortality. Now, NIV and CPAP have both been used in COVID patients, so we now well encounter these nutrition issues in this form of respiratory support. Why is there a poor intake? First of all, there's a mask, a very tight-fitting mask, and obviously you can't eat whilst you've got that mask on. If you take it off to try and eat, then often the patient will desaturate, or their blood oxygen content will go down quite quickly, so you need to put the mask on. So it's a very short time to try and get someone to eat or drink anything. Now, the air is put under positive pressure, and most of it goes into the lungs, but quite a lot of it can actually go into the stomach as well, and this can lead to bloating and discomfort. And obviously that makes people not want to eat, but become a bit anorexic. And also you can get a very dry mouth, so you find it quite difficult to eat food as well. So all these things can lead to poor nutrition intake. And of course, COVID-19 patients we know often have taste changes and anorexia anyway because of the disease condition. So if someone's not eating enough, we often think we might need to use artificial nutrition, but there are problems with enteral nutrition in CPAP and NIV. If you're using an NG or an NJ tube, it can actually cause an air leak where it goes into the mask. As I mentioned before, we can get distension of the stomach with the air and oxygen because it's putting under pressure. And that can actually lead to impaired diaphragmatic function and can actually impair the ventilation and make their respiratory function worse. So it's not something we want to make worse with feeding. So the bloating is a big problem, and again, that can lead to nausea. And generally in tube feeding, it can mean that we don't achieve full rate of feed. And there is probably an increased risk of aspiration as well. So the feed come up and go into the lungs, which is going to be very counterproductive, of course. Now, we know that in COVID-19, it's a very catabolic illness. And if someone has been on ICU ventilated, then they will probably have lost a lot of skeletal muscle and they'll have a big nutritional deficit that we have to try and replace in the recovery phase. So we are aiming to replenish this post-ICU. And of course, a lot of these patients, or some of these patients, may be on NIV or CPAP post-ICU. I've also put that it might be used pre-ICU as well, and of course with nutrition we're trying to prevent losses happening before they actually get into mechanical ventilation. So nutrition is a key thing in COVID-19, and it's a very key thing if they are on NIV or CPAP. But still, we would say that food and oral nutritional supplements should be the initial method that we use to try and increase nutritional intake. And of course, the later presentations we're going to hear in the webinar will talk about the recognition and recommendations for oral nutrition support. But it's clear from what we've seen in the literature and our experience that a lot of patients won't be able to take enough if they are on NIV or CPAP, and some of them will require nutrition support. And so which route? And because of these things we've discussed, the nutrition mythbusters of BayPen, the experts at BayPen and with the BDA specialist group thought we could use this to actually develop some guidelines for feeding in NIV, particularly around the route. Okay, so this led us to develop these COVID-19 specific recommendations. You can see all the groups that are involved in there. So there was BayPen, PENG, the National Nurses Nutrition Group, the Critical Care Group of the BDA, the British Thoracic Society, and the Intensive Care Society. And they are COVID specific, so not everything in these recommendations we would do under normal circumstances, but we think we have come up with a good set of recommendations that are very good to use in these COVID patients. So if they have got an inadequate oral intake, what do we recommend as the first line? Well, nasogastric, we think, should be the first line that we would use. It's most readily available, easily placed at the bedside, and a key thing to enteral nutrition is that you can meet nutritional requirements in quite small volumes. A lot of patients with COVID will be fluid restricted, and of course you can get 1,500 calories in a litre of enteral feed, but you won't be able to get anywhere near that with most forms of parenteral nutrition. And it's generally accepted on ICU. There's one reference there, but generally speaking, it's accepted that early enteral nutrition can probably improve outcomes in ICU. And probably in the post-ICU phase, we can say that enteral nutrition has got advantages in terms of immune function. A lot of your immunological tissue is situated in the gut, and feeding it probably is beneficial. Now, as we said, there are problems with feeding enterally in an IV, but there's lots of ways to overcome them. So we thought, when we did these guidelines, it's probably best to try all these methods before you would consider something like parenteral nutrition. So what are the recommendations? As we said, NG is the first line, but using an NG tube, a fine bore 8 French gauge would be the best one to avoid air leaks if you're putting it through a mask. Some places have got masks that are adapted for accepting an NG tube, but I don't think they're readily available. So most of the time you are putting it in through the side, and that can break the seal on some occasions. So the finer the tube, the better. Now, there's an excellent reference that is in the document that you can get on the BVA website and the BAFEM website. And this excellent reference is by Brill, and there's actually a link that will take you directly to the full text. And that talks about how you can use silicone dressings to prevent the air leaks and also to prevent pressure sores that can happen around the NG tube where the mask is so tightly fitting. Obviously, to reduce risk of aspiration, the patient needs to be sat up at an angle of about 30 to 40 degrees, and we recommend continuous pump feeding. If there is another surge and there's a shortage of enteral feeding pumps, gravity drip feeding would be considered acceptable. There were some circumstances where we thought enteral feeding would be contraindicated, and that would be if there were no feeding pumps and no gravity drip sets, we would advise against using bolus feeding in these patients just because there probably is a greater risk of aspiration with a big volume of feed going in one go. And the other time we thought it shouldn't be used at all is if the patient is prone. Sometimes for respiratory reasons, they'll put the patient on their front, as you can see in the pictures. But that does greatly increase the risk aspiration, so we said don't use enteral nutrition in anyone who's prone on their NIV or CPAP. Now, we heard that one big problem is distension of the stomach with the air and oxygen. And something we can use to probably overcome that is a gastric decompression device. And I think there are two on the market at the moment. The one that I have some experience with would be the Farrell valve, which is marketed by Avenel. And this has a channel that allows continuous decompression of the stomach during feeding. It can be used with gravity drip sets as well. And Medicina have launched a gastric decompression system as well. And they can overcome the problems with floating gastric distension. Now, I've actually, our trust have actually used this in a brain injury patient who had a big problem with aerophagia. He was always swallowing oxygen. And we never managed to achieve full feeding rate until we used the gastric decompression device. Here's a picture of the setup of one. Once the nursing staff are used to it, it's actually quite easy to set up. The only crucial bit is the valve, which is in a bag next to the feed that you can see on the drips down there, needs to be at the same height. It's actually put in line for a Y connector with the enteral feeding giving set. And the only other crucial bit is that Y connector needs to be below the area of the stomach, below the level of the stomach, as shown in that. And if you do that, it will continuously decompress the stomach as you're feeding. Another thing that we can do to help with bloating is to use drugs called prokinetics that promote gastric emptying. If we use them regularly, we can actually reduce that gastric distension. And the NICE guidelines in nutrition support say they can be used alone or in combination. Suggested doses are in the most recent ICU guidelines, and they would suggest that metoclopramide, 10 milligrams 3 times a day, or erythromycin, 100 to 215 milligrams 3 times a day, can be used alone or in combination. Espen recommend erythromycin as the first line. Now this is, is not licensed as a prokinetic. It's actually an antibiotic, but it has an action that stimulates gastric emptying through stimulating motilin receptors. In the UK, you might want to use metoclopramide as the first line as it's a licensed product, but I would be guided by your pharmacist and the physicians working in that area. But they can be used in combination as well. Now, I've got pictures of tablets there, but the route, they can be given intravenously, intramuscularly, or as tablets. I think most commonly they're used intravenously on the ICU, but again, liaise with your pharmacist and your medical team to decide which you think would be the best route for the prokinetic. Now, if all other measures fail, something you could consider, although it's very controversial, is checking something called the gastric residual volume, or GRV. And this is a way of measuring the amount of feed left in the stomach after a period of feeding. But it also helps to decompress the stomach, which is seen here. And generally what you do is you put a big syringe on the end of the, you disconnect it from the feeding system, you put a big syringe on, and just see how much feed you can suck out of the stomach after a period of feeding. And generally speaking, it's considered if the residual volume after 6 hours is less than 500 mils, then that's okay, and there is gastric emptying occurring at an acceptable rate. If it's high, you could repeat after 6 hours to check if it's lower. It's generally easier with a slightly wider NG tube, so a 10 or 12 French gauge polyurethane tube could be used. I would say you'll probably only do this on areas with experience with procedure, such as the ICU or the HDU. You probably wouldn't want to try and introduce it to nursing staff who aren't experienced on general wards. It is aerosol generating as well, so it does have implications for COVID-19. So I would say it might be a last resort, and it is a very controversial thing to do as well. Why is that? Well, it's very easy to think, like, if you put in 30 mils an hour of feed over 4 hours, you've got 120 mils of feed in the stomach. So if you suck that back out again, it shows it's not getting through the stomach or being absorbed. But in actual fact, you get a much higher volume of gastric secretions. So you can see from these that you might actually get a combination of up to 2 to 4 litres of gastric secretion and saliva in 24 hours. So it really is confusing to actually set a specific amount that indicates absorption when there could be a lot of endogenous secretions confusing it. And also, if you look at the picture there, the scan there on the sort of lower left, it shows that feed can pool in both the antrum, the upper area of the stomach, and the fundus, the lower area, and the tip of the NG tube could be in either area, so you may well miss where most of the feed is accumulated with the NG tube. And the study mentioned at the bottom there by McCrae actually showed that the tip of the NG tube could move between the different areas of the stomach within an 8-hour period, so it's quite a hit and miss procedure. So, as I said, we would probably only recommend it as a last resort. What if you've got high gastric residual volumes? What can you do? Well, you can use kinetics, obviously. Slowly, continuously feed, so minimum rate that you can get your nutritional requirements in. Controversial but high energy density feeds probably delay gastric emptying because once they get through the stomach into the duodenum, they would release more of the gut peptides like CCK and GIP that inhibit gastric emptying. So unless the patient's fluid restricted, you would probably aim to stick with the 1 to 1.5 calories per mil feed if possible. Purely based on my own experience, I think the very high energy density ones of around 2 calories per mil can delay gastric emptying. Of course, if the patient's not fluid restricted, you'd have to do big water flushes as well, and big boluses probably aren't a good idea. If there's a high GRV, always review the opiates, and if any can be stopped, that's a great idea because any of the opiates really do delay gastric emptying. And another thing that is possible, there's not a huge amount of evidence to support this, and none in the critically ill, but that whey-based feeds or non-casein-based feeds might be more rapidly emptied from the stomach because they don't form a curve like casein-based ones do. So that's something you could try again if all else fails. Nasovaginal tubes or post-pyloric feeding certainly you would think is a very good idea, but placing the tubes could be difficult in the COVID population. But you could consider it if you're in a unit that's open regularly and you think it can be done safely. Of course, there's the issue of the spreading the infection. But also, again, if you're removing the mask during the procedure, the patient can desaturate quite quickly. So the endoscopic and radiological placement could be very difficult. Some people are good at using electromagnetic systems, like the core trap system, which is pictured there. That's a possibility. And there are self-propelling tubes, but my experience is that if the patient has got delayed gastric emptying, they don't often work that well. The idea is there's a little pigtail you can see on that tube in the purple background. You just place it into the stomach like an NG tube, and then that coil moves it through with peristalsis into the small bowel. Some people find they're effective, so if you're in a unit that uses them a lot and find that they're good, you could certainly try them. Now, we certainly think that nutrition is very important in these patients. And if we tried enteral nutrition, NG feeding or whatever, and it's clearly not succeeding, you don't delay too long before you consider moving on to parental nutrition. So it should be definitely considered where enteral nutrition fails. Now, contrary to other expert groups, we actually recommended central parental nutrition as the best route, and where possible, it should be supervised by a multidisciplinary nutrition support team. So hopefully mechanisms are already in place. You need a new dedicated central venous catheter, such as a PIC, and it has to be new and dedicated to reduce the risk of infection. Existing central venous catheters could be used if they were put in on ICU, and you know that one lumen was always dedicated to parental nutrition. You need to monitor carefully for hypoglycemia in parental nutrition because there's a bigger risk of hypoglycemia due to bypassing the increasing effect. And glycemic control seems to be particularly important in COVID patients because many of them might be obese with type 2 diabetes. Peripheral parental nutrition has been recommended. I think Espen suggested this. We couldn't figure out why they suggested it as a first line because it has a very high fluid volume and a very low energy density. For example, you probably need to give about 2.5 litres to give 1,700 calories and 9 grams of nitrogen. And a lot of these patients will be fluid restricted. So, you know, if you're trying to give less than a litre, it will be a negligible amount of nutrition in peripheral parental nutrition. There's also a high risk of thrombophlebitis, so you can actually cause a significant amount of damage to the peripheral vascular access. And that can mean you lose access to essential medicines, antibiotics and things as well. Generally speaking, a short peripheral cannula will only last for about 24 hours, 48 hours with peripheral PM before you lose it. Espen actually recommends use of a midline as well, and we would certainly agree with that if it's going to be for longer than 6 days, which it probably wouldn't be likely to be. And that way you get around the loss of the vascular access very quickly. If you are using short cannulas, it's recommended that you would have 2 that you would rotate between every 24 to 48 hours, and that way hopefully you can preserve access and not lose vessels completely. So in conclusion, COVID-19 patients are at high risk of malnutrition. NIV and CPAP can lead to a poor oral intake. Some of them will require artificial nutrition, but we would recommend enteral nutrition if possible. And there are a lot of problems with using it in NIV and CPAP, but there's a lot of measures that we can take to reduce the risk, and they're detailed in the guidelines that are on the BDA and DAPEM website. Parental nutrition is indicated where oral and enteral nutrition has failed, and we recommend central parental nutrition supervised by a multidisciplinary nutrition support team wherever possible. So that concludes my section, and I'd like to hand over to Judith Merriweather, who's going to talk about nutrition in the post-ICU phase.
So thank you, Peter. I'm going to focus on nutrition in the recovery phase of critical illness, so the latter period in ITU when the patient has been extubated or decannulated, and then during the ward phase of care. I'll discuss the evidence on nutritional recovery and use this to make some recommendations about the nutritional management of post-ICU COVID-19 patients. So as many of you will know, ITU patients experience a wide variety of issues at different stages of their critical care journey. And as I mentioned, I'm going to focus on the period when the patient is transitioning from ICU to the ward and then during their ward stay. This is often the period when patients suffer the greatest number of issues. The issues that ICU survivors face often result in pronounced functional, cognitive, and psychological disabilities that impact both short and long-term recovery. The term post-intensive care syndrome has been coined to define this constellation of health-related problems, Given that optimizing nutritional status translates into improved functional, cognitive, and mental health, nutrition plays an important role in ICU recovery and rehabilitation. However, despite this, the 2009 NICE clinical guideline on rehabilitation after critical illness and the more recently published quality standards contain very little reference to nutrition. More recently, there has been increasing interest in nutritional recovery, with a number of research studies currently underway. It is well known that there's a high prevalence of malnutrition on admission to ICU and that nutritional status deteriorates further in ICU. This weight loss experienced by critically ill patients can be profound, with patients experiencing significant skeletal muscle wasting during their ICU stay. However, changes to body composition has been demonstrated when this weight loss is regained. This single patient case report found that in the 12 months from discharge from ICU, the patient had regained their body weight. Body composition measurements showed that an incredible 73% of the weight gained was due to an increase in body fat. Similarly, a study by Herridge in 2003 found that although patients had gained weight over the year since ICU discharge, the weight gain was attributed to a gain in fat mass, not muscle mass. For muscle to gain mass and quality, and therefore increase function, a combination of protein and exercise is required, which highlights the importance of a multidisciplinary approach to rehabilitation in this patient group. So if we go on to look at nutrition intake in ICU survivors, there are only a few studies that have evaluated this. One study of 50 patients from a medical surgical ICU found that energy and protein intakes were less than 55 and 37% of their respective targets during the first 7 days following extubation. Another study examined the nutritional intakes of 37 traumatic brain injury patients and found those on oral diets consumed 3/4 of their energy and protein targets, whereas those receiving enteral nutrition received 89 and 75% of their estimated energy and protein targets. In the most recent study by Ridley et al., nutritional data was collected from 32 patients during their post-ICU hospitalization period. Findings showed that patients on oral diet alone met only 66 and 60% of their energy and protein targets, with those on a combination of diet and enteral nutrition being the only group to actually receive the nutritional targets. So the question is, why are patients failing to meet their nutritional targets during their ward stay? In order to answer this, I'm going to present some of the findings from my work that aim to explore the factors influencing nutritional recovery in ICU survivors. Obviously, this research was not done in a post-ICU COVID-19 population. However, the findings can be extrapolated to this patient group. Semi-structured interviews were carried out in 17 patients on discharge from ICU and weekly for the duration of their ward stay. Observations of ward practice were also undertaken. The findings from the study showed that there were a number of factors that reduce nutrition delivery, categorized broadly into physiological and psychological changes, socio-cultural issues, and organisational failings. These three categories interrelate and compound many of the issues, as I will later discuss. Many of these factors may also affect non-critically ill hospital patients, yet their impact in ICU survivors are likely to be exacerbated because of their often prolonged hospital stay and rehabilitation requirements. So if you look firstly at the physiological changes, poor appetite was the most commonly reported physiological change. Other studies have explored appetite scores after ICU discharge, and there are inconsistent reports, with some suggesting improvements over the ward admission and others a reduced appetite at variable time points of recovery persisting for 3 months after ICU discharge. Poor appetite has been identified as one of the symptoms experienced by COVID-19 patients, and this may be compounded by the poor appetite associated with critical illness. Other commonly reported symptoms included early satiety and taste changes. Some patients described food as being bland, some reported that food tastes salty, and others reported a metallic taste when eating. The taste changes were noted to cause food aversions and changes to food preferences. Similarly, loss of taste and smell have been reported by COVID-19 patients. The presence of pain was reported by patients, and although they did not directly associate pain with a reduced food intake, it was apparent pain served as a powerful distraction. Patients who were in pain were observed to eat very little food at mealtimes. ICU survivors reported debilitating weakness and fatigue. This made eating effortful, with a number of patients reporting that they were unable to feed themselves. Some of these patients were young and found it incredibly frustrating that they were not able to do the simple tasks they previously took for granted. Patients reported changes to their sleeping patterns, commonly waking at night and sleeping for periods during the day. Sleep disturbances had a detrimental effect on food intake as patients slept late in the morning, missing breakfast, and increased daytime sleeping patterns meant that patients failed to consume prescribed supplements and snacks. Swallowing problems are common in ICU survivors, with up to 62% of patients experiencing dysphagia. The biggest risk factor is the duration of ventilation. As many COVID-19 patients have a prolonged ICU stay, it is likely that swallowing issues will be high in this group. So going on to look at the psychological changes. Low mood and anxiety were common issues, with patients profoundly affected by their ICU experience. Eating was not a high priority, as they struggled to come to terms with what had happened to them and cope with all the changes associated with critical illness. Delirium is a frequent consequence of critical illness, with patients unable to recall what they had eaten, if indeed they had eaten. A study by Mudge et al. Found that the presence of delirium was one of the factors associated with inadequate nutritional intakes in elderly patients. Social-cultural issues. A big issue that influenced nutritional intake for post-ICU patients was social isolation. Patients were transferred from ICU to a side room on the ward, and meals were eaten alone in their room, often in bed. Eating is a social activity, and a number of studies have demonstrated how food intake is affected when consumed with others. The presence of others at mealtimes has been shown to have a positive influence on food intake, both in free-living individuals and in hospitalized patients. A series of studies by De Castro showed that 44% more food was consumed when eating with others compared to meals eaten alone. Meals eaten alone were lower in calories and contained less fat than meals consumed in a group setting. Unfamiliar culture. Patients struggled with the fact that prior to hospital admission, socio-cultural influences advocating healthy choices had influenced their dietary habits, and they had been consciously choosing healthy foods. Then, after an ICU stay, they were being encouraged to eat what they perceived as unhealthy foods, high in fat and calories. With the ICNARC data showing that more than 30% of COVID ICU patients are obese, it is likely that they will be made aware of the need to make healthy choices, and this may make it more difficult for them to take on board the need for higher calorie and protein foods during their ward stay. Food habits and routine was another factor that influenced oral intake. Patients highlighted the importance of familiar foods and routine in promoting nutritional intake. In hospital, food is often prepared differently to habitual preferences, with restricted food choices and timing of meals. Many patients in the study had additional snacks brought into them by relatives, food that was familiar to them, which they had previously enjoyed. The hospital model of 3 meals a day failed to meet the needs of post-ICU patients because of physiological problems experienced by this patient group, such as poor appetite, early satiety, and altered sleep patterns, limited food intake at mealtimes. In the current climate where visitors are not allowed, it means that food choices are restricted to what is available in hospital. So moving on to organisational failings. System breakdowns and inflexible hospital routines resulted in reduced nutritional intake. ICU survivors are exposed to the same organisational issues that influenced intake in other hospitalised patient populations, for example, problems with the delivery of nutritional supplements to the patient. Superimposed on this, however, is the fact that many ICU survivors are too weak to open the supplement and actually consume it, therefore relying on ward staff to assist with this. At mealtimes, large portion sizes were off-putting to those experiencing poor appetite and early satiety. Additionally, the inability to access food overnight was highlighted as an issue in those experiencing sleep cycle changes. Communication issues. Those were particularly apparent during the transition of care from ICU, with inadequate information given to the ward. The absence of nutritional documentation resulted in a lack of clarity surrounding ongoing nutritional care of the patient. This was demonstrated by the fact that 6 of the 9 patients transferred with a nasogastric tube in situ had it removed within 48 hours of admission to the ward, without appropriate assessment of oral nutritional adequacy. These communication failures were associated with a staff knowledge gap, particularly around the need for continued enteral feeding. The NG tubes were removed on the premise that it would encourage the resumption of diet, despite evidence suggesting that enteral nutrition has no significant effect on oral intake. Enteral feeding was perceived as hindering recovery, and removing the tube was seen as a progressive step, despite the fact that patients then failed to meet their nutritional requirements. It is likely that COVID-19 post-ICU patients will experience many of the issues that have previously been identified. What we do also know is that patients often have long periods of ventilation and protracted ICU stays, leading to increased weakness and muscle wasting. Nutritional targets may not have been met in ICU due to frequent feed interruptions with proning and the severity of illness, the presence of inflammation leading to ongoing catabolism. Hence, it is important to optimise nutritional care on the ward. There are no interventional studies to guide practice, although one's currently underway. And so these are some potential strategies based on current evidence to facilitate optimal nutritional care in ICU survivors. So prior to discharge from critical care, you should really consider changing feeding tubes to 8 French gauge or 10 French gauge fine bore tubes prior to extubation or decannulation, as many patients will require supplementary feeding, and patients really hate having the tubes changed once that they are free of all of the breathing machines. So these tubes should be kept in on transfer to the ward, even if the patient has started eating. Provide breaks in feeding regimes to facilitate coordination of physical rehabilitation, and be mindful that evidence suggests that continuing enteral tube feeding does not negatively impact on oral intake. Ensure early identification of nutrition-related issues, including swallowing problems, nausea, vomiting, diarrhea, weakness, and fatigue, to facilitate appropriate interventions by other members of the multidisciplinary team. If appropriate, an explanation of the common issues that are likely to be experienced by ITU patients should be given to the patient with reassurance that these symptoms will resolve over time. It is important that a clearly documented nutritional management plan is handed over to ward staff to ensure continuity of nutritional care. A structured handover should be provided to the ward dietitian, which include details of the current feeding regime, any recent clinical issues, and the energy and protein balances from ICU. Consider using the CC3N handover for ward staff, as this includes nutritional status and baseline measures of muscle mass, strength, or function where possible. So for those who are not familiar with this CC3N handover, it's a document developed by the Rehabilitation Subgroup of the Critical Care National Network Nurse Leads Forum. It's designed as a rehabilitation handover document, which provides a summary of the patient's current status and ongoing rehabilitation needs. And I've just shown the nutritional aspects here, but it does cover all aspects of rehabilitation. So moving on to during ward stay. Supplemental enteral nutrition and/or oral nutritional supplements will be required during the ward phase of care in order to meet nutritional targets. Early satiety limits food and fluid volume, and coupled with high protein targets, the use of a low volume, high protein oral nutrition supplement is advised. Structure the timing of enteral feeding regimes around physiotherapy sessions to ensure minimum disruption to feeding. Offer a supplement after rehabilitation or exercise to ensure adequate energy is provided, and educating physiotherapists on the importance of this can be helpful. Consider the need for dedicated staff to provide assistance and encouragement at mealtimes. This is particularly important as family members are unable to come to the hospital to help feed patients. Provide small, regular, energy-dense meals and snacks. Ongoing discussions with catering staff to ensure the provision of suitable snacks is imperative. It's important to ensure the availability of snacks overnight, as I've already highlighted. Patients may experience altered sleeping patterns. Consider the need to educate ward-based staff about the particular nutrition issues faced by ICU survivors. Ensure the provision of information to the patient about the importance of nutrition for recovery and the need to eat foods high in calories and protein to achieve this. As a high percentage of COVID-19 patients are overweight or obese, discussions will need to be tailored to achieving appropriate protein targets without exceeding calorie goals. Refer to appropriate members of the MDT, such as clinical psychology if required. And we are finding that a lot of our patients are very anxious, not only due to the effects of their critical care stay, but also with fears about COVID-19. So these recommendations form some of the guidance for nutritional recovery and rehabilitation. It's been produced on behalf of the Critical Care Specialist Group of the British Dietetic Association and will be published on the website soon. So, in summary, ICU survivors have poor oral intakes during their ward stay, with a wide variety of factors influencing their nutritional intake. In light of this, nutritional targets will not be achieved without supplementary enteral nutrition and/or oral nutritional supplements, particularly during the early stages of ward stay. Protein intakes are often particularly low, so consideration should be given as to how targets will be achieved in order to promote muscle mass. Nutritional care is just one aspect of rehabilitation, and a multidisciplinary approach is important to facilitate all aspects of rehabilitation for ICU survivors. In our hospital, we have a critical care recovery pathway where post-ICU patients are seen by a dedicated team of healthcare professionals during their ward stay to ensure a coordinated approach to rehabilitation. I'm now going to hand over to Louise, who will talk through the nutritional journey after hospital discharge.
Good evening, and thank you, Judith. I will now take you through the nutritional journey after discharge from hospital. In order to do so, it may be helpful to remind ourselves that nutrition is a therapy and therefore contributes to the puzzle of rehab possibilities. Considering this phase of recovery, there has been several excellent webinars so far, including Mary Hickson and Alison Smith discussing community nutrition post-COVID, Peter Collins on nutrition for severe respiratory conditions, and the current webinar series by Van Zanten, De Waal and Wishmeyer. Today, I will predominantly focus on the post-ICU patients, but there are many similarities with current COVID populations. The ICU recovery journey and the rehabilitation pathway has distinct phases, with therapy continuing in the first few months after hospital discharge. However, as we have heard, some services do not seem to have nutrition input integral to this, therefore relying on the normal hospital to community handover pathways, which could leave patients having to adjust from having dietetic counselling on hand in hospital to providing for their own nutritional needs without much support. Adding nutrition as part of these post-ICU rehab pathways could nourish patients to improve recovery both physically and emotionally. Evidence on nutrition during the post-ICU discharge recovery phase is, however, limited. So I will therefore also present our unpublished SNAC survey data. SNAC standing for Symptoms and Nutrition After Critical Care. This was a cross-sectional survey conducted by 18 sites across the UK. It is self-reported data from 73 community patients who were previously ventilated for two days or more. The median BMI was 29 and the predominant age 51 to 80. The median point of survey completion was 3 months post-ICU. Most participants had ventilation more than 7 days. Median ICU stay was 2 weeks, and overall hospital median stay was a month. This survey explored the wide range of symptoms related to nutrition, but also included patients' report about their eating and the advice they received. The data shows the prevalence and severity of new symptoms only, therefore mitigating for the lack of population norms. Firstly, let's think about the patient at the point of discharge. What have their journey been like so far? Consider the pre-morbid health status and comorbidities. Do they have frailty because of disease burden or older age? How good was their nutrition beforehand? We know that malnutrition combined with frailty makes recovery so much more problematic. What was their nutritional status like before and now? Consider not just the weight they lost, but the extent of muscle wasting. For those overweight, is sarcopenia present? How critically ill were they? How long were they ventilated on ICU and in hospital? Because these factors determine after effects. How much time did they spend in bed worsening this muscle loss? What is their physical function and muscle strength like now, and what therapy are they getting or advised to do? Do they have symptoms like weakness, shortness of breath, poor appetite, or taste changes? How is their cognition and emotional state? And will they have the support and help after discharge? Looking at the physical factors related to nutrition, we know that patients have profound weight loss. Work by Herridge show this being 18% at discharge from hospital for their ARDS patients. Our sample of mixed ICU patients reported 11%. It is also clear that although weight loss slows in the community, it is still very prevalent, with some never regaining the weight they lost. Our survey found that 2/3 of participants had ongoing weight loss at home. We know that this weight loss is predominantly muscle wasting. Our data illustrates this by the prevalence of muscle wasting exceeding that of weight loss, which you'll see here, as well as a large proportion reporting the wasting as severe. As touched on before, 60% of our sample reported gaining weight, but not muscle. And we also found this more likely for those patients beyond 6 months post-ICU. So considering all this, this may demonstrate that, again, that sarcopenia is present irrespective of the BMI. Our therapy colleagues report a picture of significant weakness and lethargy in our current COVID patients, not dissimilar to the well-documented physical effects of post-ICU acquired weakness, of course. Our data demonstrate a high prevalence of low energy levels and weakness at 3 months, as you can see here, which supports the research previously mentioned showing patients only regaining about half of their normal function at 3 months onwards. The prevalence of other factors that can affect nutrition is also shown here, such as shortness of breath and pain. Through our survey questions, we tried to gain an insight into what patients actually make of these weight changes. We found that only 1/3 reported being concerned about their weight loss. This may reflect our great care in reassuring them that things will improve, but could also be a reflection of patients accepting their fate, or alternatively represent a potential lack of awareness of the impact of muscle wasting and the role nutrition can play. We've heard that critical illness affects physiology, appetite regulation, and digestion. And as Judith mentioned, this may present in a number of ways as depicted by the list of symptoms on this slide. The recovery trial reported patients having an ongoing poor appetite. This was scored using a visual analog scale where 0 was no appetite and 10 was the best possible. Patients scored 5 out of 10 at discharge and then recovered to about 7 at most at 3 months later. The prevalence and data for poor appetite is actually quite limited and varies dependent on how it was measured. But we found it present in half of participants at the 3 months median post-ICU. Our data did not find a clear link between symptoms and ICU clinical factors other than length of stay, but it is likely to play a role because the apparent contrast in results between those I just mentioned and that of an Australian study finding appetite not significantly lower at 3 months may in part be explained by the Australian sample seeming to be less sick and with minimal respiratory support. Early satiety was reported to be prevalent in 2/3 of our sample and taste changes in half. So with poor appetite and taste changes also reported in non-ICU COVID patients, these factors appear to be significant to be considered overall. Post-ICU dysphagia is reported to be present in a third of patients at discharge, with this lasting up to 6 months for some, especially, I guess, those with, it seems like, longer ventilation and tracheostomies. Our survey reports this present in about 2/3 of the 3 months median. So ongoing liaison with speech and language colleagues is very important for us to optimize nutrition safely. After critical illness, we also have a range of bowel symptoms reported, likely because of changes of the gut flora and gastrointestinal function due to the stress response and the medical therapy received. But what patients also report later in the recovery is hair loss, which can be quite distressing if perceived unexpected. Psychological after effects of critical illness are prevalent and well documented. Our SNAC data showed a low mood and anxiety present in about half of patients, and this was quite evident during phone calls to complete the surveys. Sleep continues to be disturbed after discharge, which can affect appetite and eating, along with a low mood, anxiety, and pain. Patients find themselves much more dependent than before their illness, with many needing help and with shopping and cooking for many months more. This dependence, the already fragile emotional states, and the current additional social distancing measures makes for complex social needs in our COVID ICU patients, which may be compounded for those living alone. Our survey data on dependence is shown here on the slide, and we found that a quarter lived at home alone. As healthcare professionals, we should be aware of the array of symptoms which may affect nutrition or represent inadequacies. We have the power to facilitate and support patients through a swifter recovery. Thinking about post-ICU nutritional needs, as highlighted by several speakers tonight and also before tonight, it appears that patients continue to have ongoing hypermetabolism in the recovery phase, which requires nutrition to be optimized. Research also points to an apparent anabolic resistance, possibly driven by an ongoing low-grade inflammatory response alongside an altered muscle physiology. This is not something I'll be expanding on tonight, as other clinicians and researchers would be better placed to do so. The nutritional requirements for post-ICU patients after discharge is not completely clear, but it appears that in order to facilitate measurable improvements, it may take a significant nutrient-dense diet for an extended period to achieve tissue remodeling. The suggested calorie and protein targets may be above that of elderly and those with severe respiratory conditions. And as mentioned here, you can see it's quite high. But it has to be acknowledged that this recommendation is largely informed by expert opinion and lessons learned from starvation studies. What appears likely is that it may require the use of high-protein oral supplemental products to meet this need. And as Judith mentioned, it should be accompanied by exercise to induce anabolism. Also possibly with some consideration of the timing and the choice of nutrients, particularly protein. However, in practice, this may prove a hard task. We found over half of patients still eating less at home than usual and generally not eating snacks. So what dietary counselling and support is currently on offer? In our sample, although access to dietary counsel was good in hospital, only a quarter of our patients reported receiving this at home. This advice was either from dietitians or others in equal measures. What was, however, clear is that a third of participants expressed an ongoing need for dietary advice. The advice received unwanted was predominantly focused on high energy and protein eating to achieve weight gain, but there was also some report of healthy eating advice. In general, this is appropriate for those having gained fat mass, but needs sufficient emphasis on protein for those with sarcopenic obesity. A third of our sample reported being advised to take oral nutritional drinks. but possibly due to the absence of continued support or guidance in the weeks and months after discharge, compliance proved to be poor, with only 40% reporting taking them as advised. Medicine management requires the appropriate use of costly pre-prepared products. Therefore, dietitians and clinicians must clearly communicate the rationale and planned review process for supplements recommended. Ultimately, the patient is at the center of all this, and good patient engagement is paramount for this very complex journey of recovery from post-intensive care syndrome. So the recommendations from the BDA Critical Care Specialist Group includes that involving dietitians in the ICU rehab pathway is the first step towards nutritional rehabilitation. This should include guidance on screening for malnutrition, first-line advice and referral pathways. There should be an assessment of nutritional status alongside quantifying muscle mass, strength and function. Be aware of and monitor for possible nutrition-related symptoms. Then add all this in a good handover to community services. Following discharge, monitor and review in the early weeks and months. Where there is no dietetic input, screen and refer where needed. The nutrition advice provided should move away from focusing on calories alone, but think about the right nutrition at the right time. Where high protein oral nutritional products are used, which is likely, include clear justification, outcome measures, and review plans. Ultimately, only a well-informed patient can play an active part in their recovery, so information provision is vital. There are some excellent resources online from the BDA, the Malnutrition Pathway, and other trusts who have developed their own. The Critical Care Specialist Group of the BDA is also actually currently working on some nutrition rehabilitation literature for patients along with the charity ICU steps, so do keep an eye out for this. In summary, nutritional rehabilitation is an important piece of the rehab puzzle because it will require a concerted effort to achieve the right and sufficient nutrition. Nutrition-related symptoms or barriers to eating are common. Dietitians can help with targeted, personalized nutritional therapy. The MDT approach is important because muscle need diet and therapy, and all AHPs should be advocates for also having protein, not just calories, because nutrition fuels and replenishes, and therefore cannot be an afterthought. We need to nourish and nurture muscles to aid recovery and optimize rehab effectiveness in the terms of function. So thank you for listening. I would now like to hand over to Danny for the Q&A session.
Great. Thank you so much to Pete, Judith and Louise for those excellent presentations. I've had some wonderful questions coming through, so I think we'll get straight into the Q&A. Apologies that I'm looking down. I have all the questions coming up on my phone. So I think we'll get right into that. And please continue to send questions through at the moment. We can definitely take some more. We've got around 15 minutes. So the first question I'm going to give to you, Louise, if that's okay. So the first question is, have you produced any specific leaflets to send with discharge patients? As our patients tend to be discharged so soon, we rarely can do discussions around that before they do get home. So are you aware of anything out there that dietitians can use?
Thank you, Danny. So for non-ICU COVID patients, I think we all can really look at the BDA website. There's a lot of references to some excellent resources on there, including the most recently updated malnutrition pathway resources. They are really, really, really helpful. So that is one area. There's also hospitals that are producing their own website with literature attached to that as well. An example more recently I can remember is a Lancashire Teaching Hospital. And otherwise, from an ICU specific point of view, we are, as a BDA specialist group, working with ICU steps at the moment, which I might have mentioned, on some patient and relative related information. So that would be useful just probably in terms of timeline for that, mid-June, hoping for that to be out, so that'll be useful for you.
Great, thanks so much. We're really looking forward to those additional bits of information when they come out. Okay, second question is for Pete. And the question is, do we have any special guidance for vitamin D supplementation or other micronutrients?
I don't think there's anything specific. Certainly, we've probably seen a lot in the general media about vitamin D. There's been a few papers, a couple published actually in the Republic of Ireland, some research coming out of St James's University. And basically, there does seem to be an association between a worse outcome in COVID and vitamin D deficiency. It probably is an association though, so we don't know there's a definite cause and effect. But certainly we know from other research that there seems to be a higher instance of influenza and chest infections, and some evidence suggesting that groups that get supplementation do better and have better outcomes or less chest infections and things like that. There was one paper showing a big association between vitamin D deficiency and the very severe reactions that they were calling a cytokine storm, where you get a massive inflammatory response and end up on the ICU. Again, just an association, but I think what all the expert groups are suggesting is that at-risk groups, so the over 65s, those of us that live in countries without much sunshine, so that is Ireland, but should probably be thinking about a supplement. Probably 10 micrograms or 400 international units is probably the minimum dose. Then you could probably take more, say 15 to 20 micrograms. I think if we're working in the hospital setting, we would aim to check the levels if we could quickly and supplement where there's a deficiency. So there's probably no harm in doing it, but it probably isn't a magic bullet. You know, it's not a major panacea that's going to save the world from COVID-19.
Okay, great, thank you. Next question for Judith, and the question is, do we have any information or data on the impact of COVID on nutritional status, so percentage of weight loss or degree of muscle wasting?
So the short answer is no, not as yet. I think there are groups who are currently working on it, but there's nothing been published as yet. I think from our experience, patients do lose a lot of muscle mass and weight, particularly those who've had longer ICU stays. So, but that's obviously anecdotal.
Yeah, absolutely. And just to add to that, I think Paul Wishmeyer in the US is undertaking a study at the moment looking at muscle wasting with ultrasound in the COVID patients. So we'll, I guess, eagerly await some of his results that come through. Louise, a question specifically directed to you in the questions. A good question. It says, hi, Louise, interesting point about hair loss post-ICU. Is there specific nutrition advice for this? Should we just be reassuring patients that this will improve with time, or should we consider vitamins or trace elements screening or supplementing?
Okay, thank you, Danny. So there is no research with specific links to specific micronutrients for hair loss. It does very much depend on the patient's journey. The stress response is the main factor. There's other things about hydration levels, also a major factor. There is some suggestion that an iron status might have a role, and also some of the B vitamins, but really there's nothing really majorly going out. You can't really draw a conclusion, a final conclusion on the current data. So unfortunately, it is reassurance. And absolutely, that's the most important thing, because it is quite distressing. And just giving them that information that it might happen, and doesn't happen with all of our patients, but it will regrow quite well, is really what we need to do.
It is really common. We see it quite a lot in our follow-up clinics, for sure. Thank you. And great question. Next question is for you, Pete, again. So the question is, what would be your largest water flush you would allow in NIV enterally fed patients? As we find high sodium is a regular concern, requiring low sodium feed or additional water flushes.
Interesting question. Well, there's not a definitive right or wrong answer to this, definitely. Intuitively, I don't know, I always think the figure of 100 mils, but that's purely my intuition. What I would say though is, if they're requiring more fluid to bring their sodium down, you could think about a less energy dense feed, because then it's going in continuously at a slower rate than putting in a big water flush. So always consider that before thinking about putting in extra water, and it is a really difficult situation if they want to strictly fluid restrict them and they think that hyponatremia is a consequence of dehydration. So you really have to think about it. But one thing I would say is always look at the medicines they're getting and see if you can change any of those. I mean, if they're using effervescent paracetamol, you get about 150 millimoles a day of sodium from that. And unfortunately, all the IV antibiotics are given in saline, which is 154 millimoles per litre. So, if there's anything you can change to change their intake, and if they've got a high chloride, that might suggest it's a high intake of sodium and chloride. Always have a chat with the pharmacist and see if there's anything you can change there.
Great, thanks, Pete. Next question is for Judith, also a really good question. And it is it known for how long physiological and psychological changes following ICU may last?
No, it's very variable, dependent on the patient. So with the research that has been done, some patients have experienced symptoms at 3 months, some for as long as a year. So I think it's very much dependent on the patient, and it's important to monitor them throughout this period, because obviously sometimes certainly the psychological symptoms can occur at a later stage for patients. So that's where it's key to follow them up and have an idea of what's actually happening with them.
Mm-hmm. Great, thank you. Next question is another one specifically for you, Louise. It says, question for Louise. There's actually 2 parts to the question, so just let me know if you'd like me to repeat it. The first one says, how are you measuring muscle mass in routine practice? And the second one is, are you giving any advice on the timing of consuming protein? Before or after exercise, do you need to aim for a maximum amount per meal?
Okay, so the first part of the question, in our hospital, we do not measure muscle mass, but I know in many other hospitals, like in yours, Danny, you do. So in certainly areas where you do a lot of research, you do the ultrasound. We do more functional assessments. So in our pathway, it is much more functional than mass, really. But as dietitians, you've got all the additional measurements you could do in terms of mid-arm circumference and then the tricep skin fold to calculate the muscle mass, but the distribution of your muscle wasting over your body might be an element to consider, and also how quick your fluid retention improves and how that impacts on those measurements you need to consider. So they're not without fault,
okay.
I guess. So the second question was again, sorry?
The second question was about the timing of protein, which is, are you giving any advice on the timing of consuming protein? So before or after exercise, or do you need to aim for a maximum amount per meal?
So we don't, at the moment, just from a practical point of view, we generally give our nutritional supplements in addition to our meals. And generally it is after exercise, because of the practicalities of having to do an exercise with something in your stomach. It is better. So with the research out there isn't a lot of research regarding the timing of it. And it seems like most of the research is in elderly patients in terms of the timing, and any meal consumed within what appears to be an 8 to 12 hour period really has a positive effect. So I don't think there's a lot about the timing right now, a lot of opportunity for research, but at the moment there isn't. Again, looking at the elderly group, they probably need a higher dose of protein to really induce the anabolism, where most adults will probably, at a normal dose, will be 20 grams per supplement or per snack is probably the most you can achieve. Elderly, it probably looks more like 30, 40. So, but it's really difficult practically to get that in, and that's where a lot of work is needed in this area.
Yeah, I agree. And I think this is an area that is ripe for research if anyone is interested. And just to add to your point about the ultrasound for measuring muscle mass, and to say it's not really ready for clinical practice yet, it's definitely a research tool only. So watch this space. Okay, last question probably before we need to log off, because it's almost 7:45. I'm going to ask Judith this one as well, and there are a few similar questions around this, and if any of you, Pete or Louise, want to chip in as well, please do. But the question is, what protein requirements would you suggest to use on patients who are now in the rehabilitation phase, and for how long would you recommend that these are continued for once the patients go home?
Well, I think the key is just to actually get protein into patients, which is often the most difficult thing. I think aiming for 1.5 to 2 is what's been suggested in the evidence, but actually practically that is incredibly difficult. And as to how long, I think, again, it really depends on the individual patient, and that's where it's important to monitor them. And, you know, again, when they go home, to follow them up from there. So nothing's sort of set in stone, but I think monitoring will be key to assess.
Yeah, I agree, absolutely. That's good. Again, another area ripe for research, I think. Excellent. Okay, well, we're spot on time. There are still quite a few questions left to answer. So I think what we'll try and do is an FAQ and post that back on the website, and also put it on Twitter so that we can actually answer quite a few of the questions that have still come through. So I'd like to thank Pete, Judith and Louise for presenting tonight. You all did a really great job, and thank you to all of you for watching. I just want to leave with one last thought because I can't help myself, and I said this in the previous webinar we did, and that is that I guess one of the aspects that's come out of the COVID-19 pandemic is a real focus on rehabilitation after critical illness and a particular focus on nutrition. This is not new. ICU patients have required rehabilitation and nutrition support post ICU for a really, really long time. So I think that if anything, this has really highlighted the need for us to be including this more regularly in our practice and perhaps researching it a lot more, not just in the COVID patients, but in our non-COVID ICU patients too. So I hope that it's really highlighted the importance of post-ICU nutrition, and that going forward, we will be able to have much better rehabilitation pathways for these patients. So with that, I'm going to leave you. So I hope you all have a wonderful evening, and thanks again to our speakers and to Nutricia for hosting. Have a lovely evening.